The session this morning is on metal bearings, and the organizer asked me to start by making a few comments on the North American perspective. So when you go back and you look at the history of hip replacement, the issue really has always been wear. And I think everyone recognizes Sir John Charnley and the Teflon socket, where the first several hundred he did failed because of massive wear and osteolysis. We went through the cemented period and the hybrid period, and cementless implants were introduced in North America in the 80s to take care of the problem of so-called cement disease. And we quickly found out it wasn't cement disease, it was particle disease. And we had horrible problems with osteolysis with the first generation cementless implants, especially with the polyethylene manufacturing techniques at that time. And a lot of these patients, like this patient who was a 50-year-old woman, at 5 years postoperatively had severe pelvic osteolysis and no symptoms. This was a typical foreign body reaction, right? So you have a macrophage reaction to foreign particles leading to activation of bone-resorbing cytokines and lysis. So in the late 1990s, several new bearings were introduced. Highly cross-linked polyethylene, metal on metal, and ceramic on ceramic. Obviously, metal on metal and ceramic on ceramic were a resurgence of technologies that were available a decade or two before. And you have to keep things in perspective, because at the time these were reintroduced, again, we were having bad problems with polyethylene. So it was, I think, justified at that time to go and look at these technologies, but we're not there anymore. The goal with this was to reduce the particle load by reducing the wear volume. The hypothesis was that if you reduce the wear volume, you'd reduce the incidence of osteolysis and the incidence of aseptic loosening. So that was the thing that we hoped would happen, and now we have data to tell us whether it really happened or not. So the question is, where are we 10 years later? Well, I think femoral component fixation is solved. If you do a cementless femoral component of almost any design, and you put it in so that it's tight at the time of surgery, it will osseointegrate 99+% of the time. It's not an issue. We now have 10-year data with the new bearings, and what we're seeing, unfortunately, is some unique complications with the metal-metal articulations. There's a spectrum of adverse tissue reactions we see. Some of them are just straightforward foreign body reactions, so you'll see a macrophage infiltration. Some of it's toxicity. We know from cell culture studies that I'll show you that cobalt, especially, is very toxic to cells. So at very low concentrations of cobalt ions, you will kill the tissue. There's this probable hypersensitivity that accounts for this lymphocytic infiltration you see histologically, and that has been termed ALVAL. Remember, ALVAL is not a clinical diagnosis, it's a histologic diagnosis. And if you look at the tissue around a metal-metal implant, whether it's failed or not, you'll often see that histopathologic findings of lymphocytic infiltration. This is the paper that I really think brought the attention to the world. It's out of Oxford, and they reported on their pseudotumors associated with metal bearings back in 2008. And I think pseudotumor maybe not the best word for it. It's really a foreign body reaction, local cell toxicity, cell necrosis, and a cyst formation. And they were associated with extensive necrosis of the tissue, lower Oxford hip scores, and in general, these patients had high serum cobalt levels. Interesting, in their study, these were all female. Now, in the North American experience, my co-moderator has one of the biggest experiences with metal-metal total hip replacement in the US, and he reported on almost 2,000 metal-metal total hip replacements that were done at his institution between 2002 and 2006, and you can see the average age of these patients is relatively young at 57, and they had about 3-year follow-up on average. And if they looked at their rate of complications, and their overall reoperation rate was quite high, and we'll ask Dr. Lombardi to comment on this. It was about 5%, and you can see the reasons for reoperation: 4 dislocations, so relatively low incidence of dislocation, some infections and some stem failures. But you look on the cup side, and there was a 3% cup loosening. That is very different than our experience with metal on polyethylene. And I think since the time of this report, actually their rate of revision has actually gone up. I'll show you a few of the reactions that we've seen, and in our experience, they aren't all women. They're predominantly women, but they aren't all women. So this is a 65-year-old male who was 4 years status post his resurfacing, which was part of a FDA study in the United States. And he presented with pain and swelling around the hip. He had a fluctuant hip. And you can see as you cut down through the tissues, the fluid in that was under pressure. And when you look at the reaction around this implant, you see the extensive necrosis. And this is the typical finding that we see in the more severe reactions with the metal debris. If you look at the histology in these cases, it's a combination of lymphocytic infiltration and fibrosis, which you can see in this slide, and cell necrosis, which you can see in this slide. So again, very typical histopathologic findings that are much different than polyethylene or cement or titanium, where you tend to see a macrophage infiltration with giant cells. Here you see cell necrosis and a lymphocytic infiltration. This is another case of a 65-year-old woman who presented with 2.5 months of after bilateral total hip replacements. She had a history of chronic allergic dermatitis and an allergy to nickel, and she presented to our institution with pain and swelling in her right leg. This is her MRI scan. You can see the difference between her right leg and her left leg. If you look at the MRI on the right side, you can see the pseudotumor, which tends to go up the iliopsoas tendon into the pelvis, and in this case is displacing the bladder to the left side. And this is what her leg looks like on the operating table. You can see they thought it was initially a DVT, and then they thought maybe she had a tumor, and in fact this was just an adverse tissue reaction to the metal bearing. Very extensive soft tissue necrosis. You can see this is the femur. All of the abductors were necrotic. The proximal femur in this case was necrotic. Here it is up close. Here's the debris that we debrided from this particular case and did a revision to a metal on polyethylene total hip replacement. The bad reactions we've seen have been predominantly in large head total hip replacements. That's number one. Number two then would be resurfacing. Not so much in the smaller 28 millimeter metal from the Metasol days, but occasionally we do see this reaction. Here's one of the more severe ones where you can see a 28 millimeter metal on metal Metasol bearing. This is obviously metallosis, but not the same type of necrosis, interestingly enough, that we saw in the last case. And you can see this had extensive damage to the femoral head and to the metal bearing as well. Again, in a close-up of the femoral head. Now, if you look at the cellular reaction to the different metal particles, I think it helps tell us the story. This is a study we did now almost 20 years ago. It's published in JBJS in 1993, where we looked at serial dilutions of cobalt, chromium, titanium, aluminum, and looked at the difference in the cellular reaction to these metallic debris in the ions. And this is a scanning electron microscopy of cells exposed to these metal debris. And on your left is titanium. Titanium is inflammatory like polyethylene. It will be phagocytized by cells, whether they be macrophages or fibroblasts. It doesn't tend to kill the cells, but it stimulates the secretion of bone-resorbing cytokines. At the same particle concentration, cobalt kills the cells. And I think that explains some of the histopathology we're seeing around these failed metal cases. The other thing that's important, and we'll ask Dr. Lombardi to comment on this as well, is that you probably should intervene early. If you have a patient who's got a symptomatic metal-on-metal total hip replacement, you probably should intervene. We don't know exactly when, but if it's symptomatic, it's probably a malfunctioning bearing. Usually the ion levels are high, and if you let it go to a point where you have significant tissue necrosis, you will have a poor outcome on the revision. So intervene early. Now, if you look at the last comment I'll make is looking at some of the registry data, because remember, we now have up to 10-year data with these bearings starting in the late 1990s, going to now 2011. And this is the data from the Australian registry looking at total hip replacement in patients with a 28 millimeter head or smaller. It's adjusted for age, which is a surrogate for activity. It's adjusted for gender, which is a surrogate for bone quality. And you can see in this data, looking at the 4 to 5 year data, clearly the poorer performing bearing is the metal on metal, and the best performing bearing is the metal on highly cross-linked polyethylene. Now, if you look at the bigger head sizes, you see the same findings. So this is head size greater than 28 millimeters, so 32, 36, 40, adjusted again for age and gender. And you see the results where the data is still really good at 4 to 5 years. The failure rate with the metal-metal is about twice as big as the failure rate with metal on polyethylene. Now this is right out of the Australian registry. If you're interested, you can go to the Australian registry. This is online, and you can see the data. It's actually very interesting data for a lot of different technologies. The England and Wales registry has really come online in the last year or two, and this is the data looking at fixation strategies in bearing surfaces in their country or countries. And you can see now at 4 years, actually the best performing total hip replacement in the first 4 years. This isn't adjusted for age and gender yet, but you can see it's actually a cemented total hip replacement, which at least in North America, not many of us do anymore. The worst performing total hip replacement was a large head metal on metal. And you can see the survivorship at 5 years for the large head metal on metal. Already about 8% of them had failed. If you look at a cemented total hip replacement or a cementless total hip replacement, you're talking about a 2 to 3% failure rate. So you're talking somewhere between a 3 and 4 times greater failure rate with the metal-metal. So I think at this point in time, it's appropriate to step back and look at the data and make a decision what we're going to do for our patients in the next 10 years. And that'll be the focus of this talk, looking at metal-metal, and maybe by the end we can come to some consensus on where metal-metal should be used in this day and age. So I think with that, we'll go ahead and ask Dr. Lombardi to make a few comments on his experience in metal-metal, then we'll go to the first paper. Adolf?
Yeah, thank you, Bill. Well, I think as Bill pointed out, I was experiencing a fair number of problems with polyethylene in the late 90s. Bill made the right decision and stayed with polyethylene in a highly cross-linked fashion, and I had decided at that point that I had already been burnt by Hylamer and decided that I would go through the metal-metal experience. And early on, it was very positive. We did a lot of 28s and 32s, and then as we moved to the 38s and now the large heads, we're starting to see obviously what he's pointed out here, that there have been some significant issues that have arisen. And so in my own experience with the large head metal on metal hips, loosening has been an issue because I think fixation is a problem when you take a chrome cobalt cup and you put a layer of titanium on it for bone ingrowth. It's just a different animal than putting a titanium cup in with either a plasma spray or beaded surface. So I think fixation has become an issue. Plus, obviously, with the large head, there's a little more friction. And I think the other thing that that Bill didn't actually say, but I'm sure he's alluded to, was the fact that one of the other issues with the large head is the fact that we have a lot more of this crevice corrosion issues that complicate the metallic debris and the burden to the soft tissues, and perhaps that's why the large head metals are a little worse in our experience than the resurfacings. So at this point, I find my only indication to do a large head metal is still in that very active male. Other than that, I've gone strictly to using a highly cross-linked polyethylene, a second, third generation right now, and in my high demand individuals, I'd use a ceramic head.
So that's our perspective, and we're looking forward to seeing what the rest of the world thinks. And Dr. Orsini is here. Let's put up the next talk, please. I'd like to introduce the first paper. Dr. Orsini from Italy will present 9-year clinical experience with metal-metal hip resurfacing.